Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. The series is published for over 30 years, and for our seventh podcast, we will be discussing the October 2022 issue devoted to oncology imaging. I'm John Vasallo, managing editor of the series here at Elsevier, and during this podcast, we will discuss 4 articles from the issue, 2 on aspects of lung cancer, 1 on breast cancer, and 1 on malignant glioma. Leading this discussion will be our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of the oncology imaging issue, Dr. Natalie Louie, assistant professor of cardiothoracic surgery at the Stanford University School of Medicine in Stanford, California. Welcome to both of you, and over to you, Dr. Pollack.
Thanks, John. I appreciate that introduction. Super excited that we have with us today Dr. Louie from Stanford, who is a national expert in imaging and oncology. Dr. Louie did a wonderful job amassing a number of national and international experts on this topic for the most recent volume of Surgical Oncology Clinics, and we're delighted to have her with us here today to discuss several of those articles. So welcome, Natalie.
Thank you so much for having me today.
You bet. I thought maybe we could start off with 2 articles on lung cancer, and maybe we can start on the article that you were the primary author on, which was a review of intraoperative molecular imaging of lung cancer. I know that intraoperative imaging is a hot topic in lung cancer, but also other types of malignancy. And I was wondering if perhaps you could give us a brief overview of the concept of intraoperative molecular imaging and how this technology may be applicable to lung cancer, but then also perhaps even other cancers beyond pulmonary malignancies.
Sure, happy to. Currently, we use mostly CT scans, often PET scans, and then, of course, what we see grossly in the operating room to make most of our operative decisions. But there is a lot of information at the molecular level that we just don't see with these modalities. And so intraoperative molecular imaging is really a newer technology that tries to take advantage of these changes in the molecules in tumors compared to the surrounding tissues so that we can have additional information to guide us. So this article I wrote with Dr. Sunil Singhal at the University of Pennsylvania. He has really been leading our field in these studies. Really reviews the trajectory of intraoperative molecular imaging over the past few years, starting with non-targeted agents that were not very specific to tumors, so thus not as helpful, and then non-infrared, near-infrared agents, which really could not penetrate the lung very well. And so most recently, he's been studying an agent called OTL-38, which is both targeted to a full-weight receptor as well as near-infrared. And with these 2 characteristics, it was really a lot more effective in finding lung tumors, lung cancers during surgery.
That's really interesting. I was wondering if you could maybe just touch on what are some of the characteristics of an ideal imaging agent, if you will? Thinking about the different imaging agents that you highlighted in the article, not near infrared, targeted, untargeted, whether it be lung cancer or other cancers. What should clinicians be thinking about when they think about imaging agents and their characteristics?
That is a great question, and there are a lot of different characteristics that are important. So the 2 that I mentioned, the first being targeted. So we want an agent that really localizes to the lung cancer tumor and not other surrounding tissues, so that when we see it in the operating room, we can be very sure that that represents lung cancer. Second is near infrared, which is one issue with imaging the lung. So you asked earlier about how this might be applied to other types of cancers. There are others like head and neck where the tumor is essentially apparent right in front of the surgeon. So the fluorescence does not need to penetrate very far. Whereas if we are looking for a small lung nodule that's more than a centimeter deep in the lung, then it can be very hard to get a fluorescence signal from those. So those, I think, are the two most important characteristics in the lung. But there are several others that come up. For example, we'd like an agent that has very few side effects that we can give easily. The last agent that was discussed in the article, panitumumab IRD800, that's one that I've been involved in studying. That's an epidermal growth factor receptor, or EGFR antibody, that is conjugated to a fluorescent dye. And that one in general needs to be given at least 24 hours before. So I'd say that is a disadvantage of using that we have to have the patients undergo an infusion at least a day before surgery, which logistically can be hard.
And then when thinking about these molecular imaging agents, from a clinical perspective, are they mostly to be used to find perhaps a difficult to identify primary tumor? Is it more to identify maybe additional tumors that weren't detected on preoperative axial imaging? And then what's the role of molecular imaging, kind of like real-time margin assessment in the operating room?
This is a question that has actually changed just recently. So yes, it is mainly being used to identify lung nodules with more advanced or higher resolution CT scans over the recent years and the advent of lung cancer screening. We are finding smaller and smaller tumors, and we want to take them out. With this, just recently over the last year, there have been a couple randomized controlled studies that have shown that sublobar resection, so taking out less than a full lobe of the lung for early stage lung cancers, is non-inferior to lobectomy. We as thoracic surgeons have been doing that in practice for years, and now there is actually data that shows that our presumptions were correct. So more and more thoracic surgeons are going to be finding small lung nodules and wanting to take out a small amount of the lung with an adequate margin. And these lung nodules can be very hard to find. So if they are not right at the surface, if they are part solid, they can be quite hard to find, especially using minimally invasive techniques, VATS or robotic, where it is pretty difficult to palpate the nodules. So yes, I think these types of technologies, including IMI, intraoperative molecular imaging, will be even more important as time goes on, mostly for finding the primary tumor, although in several of Dr. Singh's studies, he has found additional nodules that have turned out to be malignant. So that is something to study. And I think margin assessment will be a big part of that as we're performing sublobar resections.
Yeah, that's a perfect segue to the next article that I wanted to discuss with you today, Dr. Louis. And that's Dr. Sachdeva's article on imaging to aid in segmentectomy for lung cancer. And you touched on that, but perhaps we can dive a little bit deeper into how advances in imaging has allowed surgeons to do perhaps more targeted pulmonary segmentectomy for early stage lung cancer. So in particular, I was wondering if you could help us understand how intraoperative imaging may help the surgeon define intersegmental planes or sentinel lymph nodes as part of resection for early stage lung cancer.
Intraoperative molecular imaging is being used already to define the intersegmental plane. I'd say a lot of surgeons use indocyanine green, or ICG, which Dr. Sachdeva mentioned in her article. And that is generally used when the segment has been devascularized. And so ICG is given intravenously, and within a few minutes, you can see the blood flow through the rest of the lung that still has a vascular supply. And then that can show the area of parenchyma to be removed quite easily. This does not show the tumor itself, unlike the intraoperative molecular imaging techniques that we described in the first paper. So really, we have to know the anatomy based on the preoperative CT and understand which segment to target. And then this lets us make sure that the intersegmental plane is correct.
And then you had also touched on the use of intraoperative imaging and novel imaging techniques as they relate to robotic-assisted segmentectomy. You know, more and more, I know thoracic surgeons are using a robotic approach. And I was wondering if you could maybe highlight some of the special considerations around intraoperative molecular imaging that may be particularly pertinent to robotic surgery.
There are a couple things that I think are useful from the robotic approach. One is that the Firefly fluorescence imaging is built into the camera. And so this can make it quite easy for the surgeon to switch between white light and fluorescence imaging very easily. And that will help with using intraoperative molecular imaging. I think otherwise, the robot is mostly helpful in terms of the wristed instruments, in terms of getting around smaller vessels and airways.
Great. Well, moving on from lung cancer, I was hoping to pivot to breast cancer. As I noted, this volume of Surgical Oncology Clinics really did a fantastic job of touching on a number of different malignancies. And in this chapter by Dr. Mukhtar, the topic of molecular imaging for estrogen receptor positive breast cancer was tackled. I was hoping maybe you could touch a little bit on the promise of molecular imaging for breast cancer and its potential application for, tumor detection or response to therapy, or even as a potential tool to guide treatment strategies or improve surgical approaches.
Of course. Dr. Mukhtar's article discusses a new radiopharmaceutical called fluoroestradiol, or FES, which was approved by the FDA in 2020 for recurrent or metastatic disease in the ER-positive setting. So that's about 75% of breast cancers out there. And currently, there are a lot of disadvantages with our techniques. For example, if a patient's tumor is biopsied and they get just a few cells and determine whether it's ER positive or negative with that, you only get a very small sample. Whereas using FES with a PET, then you actually get to look at the entire tumor. Similarly, if patients have heterogeneous disease, for example, in the metastatic setting, and some tumors are ER positive and some are ER negative, you can't really actually biopsy every single one, but you can scan using FES and really get a lot more information.
And then I know in the article there was also some discussion about how FES may assist with therapy selection and assessment of treatment response among women with advanced breast cancer. And I was wondering if you could perhaps touch on that.
Yeah, they have found that women with ER positive breast cancer who have higher baseline FES, that predicted response to tamoxifen could be used to guide treatment in that way. This is really only for patients with ER positive disease, but that is the majority of patients. So I think it has a great potential to guide treatments in that way.
Is there any different application of FES with regards to the specific subtype of breast cancer that we may be dealing with? I know there was some discussion around invasive lobular carcinoma as perhaps FES having a particular benefit in this subset of women.
Yes, thank you for asking. Dr. Mukhtar is an expert in invasive lobular carcinoma, and so that is one of the reasons why she is interested in FES imaging. Invasive lobular carcinoma is known to be sensitive in using FDG PET, which is much more standard. And so some people are studying the use of FES PET for that subtype of breast cancer in particular.
To follow up on that question, you were noting that perhaps FDG PET is less sensitive for invasive lobular carcinoma. What is the role and sensitivity of FES imaging in the evaluation of liver metastases, which are a subset of women with breast cancer who have metastatic disease that may be a site of distant spread?
From what I understand, FES has standard expected uptake in the liver and the GI tract, so I don't think it would be useful in that setting.
I agree. As a liver surgeon myself, I was interested to note the comment in the article that there's already a high level of normal physiologic uptake of FES in the liver that results from rapid metabolism of the agent, and therefore some have concluded that FES PET should not be used to evaluate liver metastases. That was a very interesting point that I was not familiar with and took home from this article. I was wondering, as we kind of conclude and wrap up on this article, any thoughts on the future directions of FES PET? Is it FDA approved, and is it currently being utilized right now amongst our breast surgeons and breast medical oncologist colleagues?
It is FDA approved in the recurrent or metastatic setting. It was approved in 2020, but I do not think that it is standard yet. And so I do think more studies will be necessary to really determine which part of management it will be most helpful in, whether that's initial staging, as you asked about treatment prediction, or really restaging after treatment. And I think that with some more studies and perhaps cost effectiveness analysis, it could really help change our management of breast cancer.
Thank you, Dr. Louie. So I wanted to now move on to our last article that we were going to discuss today, and this is on malignant glioma by Dr. Hayden Gephardt and colleagues. And this article in particular discusses the use of 5-aminolevulinic acid as a molecular non-fluorescent pathway to evaluate malignant gliomas. I was wondering if you could perhaps comment on a little bit just what is 5-aminolevulinic acid and why would this be pertinent to gliomas?
5-ALA is another agent that's been recently approved. I think it was in 2017. So it's really fascinating with both of these articles, how recent this research has really made a clinical impact over just the last few years. So 5-ALA, as you said, is a non-fluorescent agent. It's an intermediate in the heme biosynthesis pathway. So one interesting thing is it's converted to protoporphyrin 9, which is fluorescent. And that, for some reason, accumulates in high-grade gliomas. And so neurosurgeons have been using this for several years to guide their extent of resection.
I'm wondering if you could just talk a little bit about specifically how neurosurgeons use 5-ALA in clinical practice. And what does that look like? I assume it's given preoperatively, and then is there some intraoperative assessment that is performed that allows them to help tailor the extent of their resection based on this fluorescence?
Yes, exactly. So it's given before surgery, about 3 hours before induction, and it's dosed by weight and dissolved in water. The authors noted that the standard had been to give it 3 hours before, but some newer studies showed that it actually peaked a little bit later. And so it could actually be given a few hours earlier if that was more convenient. So this is, as you asked before, what important characteristics of intraoperative agents that people look at. That's one of them. How convenient would the administration be? And so the authors show some really interesting photos of intraoperative imaging. During the tumor resection, they switch from white light to blue light for tissue excitation. And they note that that wavelength is about 400 nanometers. And then they visualize through their microscope with a red-violet light filter the protoporphyrin 9 induced fluorescence. So they have a few really great photos in the article that demonstrate this.
You know, I thought it was interesting in this article that the authors did highlight some data to suggest that there was an actual benefit from using 5-ALA fluorescent-guided surgery. I don't know if you wanted to comment at all about those data.
Yes, of course. They have a table that goes through a lot of the studies about 5-ALA, and it is really impressive to see the differences, most importantly in the extent of resection. So some of them have really doubled the proportion of cases in which a gross total resection is complete, from about 50 to 95% in the 5-ALA group compared to about 23 to 50% in the conventional white light group. And because of that increased extent of resection, the patients where 5-ALA was used have been shown to have a much longer 6-month progression-free and overall survival. And this is in both randomized controlled studies as well as prospective studies. So it's quite a dramatic change based on this fluorescence guided surgery.
Yeah, I found that very interesting also, that the data that showed better outcomes with 5-ALA FGS compared to controls. The other thing I found interesting was this notion using 5-ALA acid not only as an imaging agent to assist with surgery, but also perhaps to partner it, if you will, with photodynamic therapy from a therapeutic approach. And I was wondering if you could comment on 5-ALA as dual imaging and photodynamic therapy.
Yes, the authors talked about using 5-ALA for tumor resection, as we were just discussing, but then using photodynamic therapy at a different wavelength and applying it to the resection cavity. So that would produce cytotoxicity and local ischemia to the resection bed. So this is really a future area of research, but very exciting given how successful 5-ALA has been integrated into their intraoperative protocols already.
Well, thank you so much, Dr. Louie. I was wondering if you had any final thoughts about kind of the future of imaging in oncology, molecular imaging. What do you think the future holds, and how will surgeons and other members of the multidisciplinary cancer team be using imaging, molecular imaging or otherwise, in the future?
Well, it was very clear when I was putting together this issue that we have come a long way in just the last few years. There's been FDA approval of 5-ALA in 2017, FES in 2020. Since I finished my training, it's really amazing how far these have come. And I think that the field of research is so exciting now. There are a lot of different applications that we have discussed today that I look forward to in the future. I think that surgeons are really hungry for additional information besides what they see right in front of them, to be able to incorporate that information to improve their surgical treatment of cancer patients.
Yeah, I think you're right. This is an extremely exciting field. It's a quickly changing and emerging field. And I think all the more reason why this topic was so important to address in the most recent volume of Surgical Oncology Clinics. And I want to thank you and congratulate you, Dr. Louie, for putting together a wonderful group of co-authors and authors of these papers that really highlight the latest data, information, and technology around cancer imaging, which I know will benefit our readership immensely. So once again, thank you for being a guest editor. And thank you for taking time today on this podcast to share with us your immense knowledge on the subject.
Thank you so much for having me today, and your leadership and John's help with putting this issue together.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to oncology imaging updates and advancements. The 4 articles discussed, as well as 6 others, are in the October 2022 issue, Volume 31, Number 4. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgeonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.